So is there anything you would like to tell us, just sort of in opening remarks? We've had some evidence from you, and thank you very much for that. That's been really helpful. And I think you've also declared any sort of conflicts of interest that you might have. I think that's on the record too.
Thank you. Yes. So, I mean, obviously in preparation for this, we've been looking out, we've seen some of the previous videos of people have given evidence, we've had people contact us, and we were made aware of perhaps 3 areas that I thought I might be able to add some supplementary information as to what we've already submitted in evidence to you. So I have prepared some information in sort of the form of a statement that I can sort of read bits out. I certainly didn't think it was appropriate to read out the fairly significant submission we've already made to you. And obviously I'm very happy to take any questions that any of you wish to put to me. I do not pretend to have encyclopedic knowledge of every element of this, but the reason I have brought 2 colleagues along with me from the college is that if there's anything specific that we establish that you have further information that somewhere in the college can provide, that they're making notes that we can get that and get it back to you. So yes. That's why I have my colleagues with me, if that's okay.
All right, that's splendid. So if I could just start by just sort of saying that, first of all, my dad was a GP, so I grew up in a GP's household. He joined the NHS in 1948, so right at the very beginning.
Very important, yeah.
And sadly, of course, he's no longer with us. But just sort of thinking about your organisation, it is a membership organisation, and again I've chaired a number of membership organisations, and they are actually quite difficult because it's not like something that's statutory, and you've got certain rules and things you have to comply with, but certainly as a Royal College I'm sure you do have some of those. So thinking about the written evidence that you sent us, I'm just wondering from the point of view of the college, and I know that you're not a regulator as such, but can you just tell us a bit more about how you promote safety and how you set your high standards of practice that you expect GPs to operate under? And also in that context as well, can you say how you ensure that those standards are met?
Okay, so rather than go through because the 3 sections that I prepared were the role of the college in updating our members, a bit of information about the history of Primados, and some feedback on a fly on the wall documentary that was talked about in a previous hearing. Shall I just put those to one side and take questions?
If you'd rather, if you'd like to put that on the record, do by all means.
Shall I do that? Because it might, I think there's probably going to be quite a large degree of overlap in what you're asking, and rather than repetition, would that be okay?
Yes, do that. Yes.
So thank you so much for asking asking myself or asking the college to come along and add to the dossier of evidence that we've already supplied to you. So yes, I'm chair of the Royal College of GPs, which effectively is equivalent to the presidents of the other colleges. The Royal College of GPs is the largest of medical Royal Colleges. We have over 53,000 members, and you're quite right, Royal Colleges are not regulatory, they're not statutory, they're membership organisations. So we are independent, and our expertise is patient-centred independent practice. We're absolutely the largest membership organisation of GPs anywhere in the UK, but we also have members around the world. So over 3,000 of our members are internationally based. And our commitment is to improving patient care, developing GP skills, and promoting general practice as a discipline. So that's kind of the starting point. So the 3 issues, if you're happy. There was a TV episode broadcast in the autumn. Now, this was brought to our attention by the Fetal Anticonvulsant Syndromes Awareness Group, Facts Aware. So I think they brought it to your attention. And didn't see the episode myself, but I'm now aware quite a lot about it. And apparently in November, Facts Aware raised concerns about one episode where there was in one clip a GP seemed to be acting in a way that suggested GPs had specialist knowledge of epilepsy management, which one would not normally expect. And so one of our college members, Dr. Judy Shakespeare, investigated this. She contacted the GP involved directly. And it turns out that he's a GP with a long-standing specialist interest in epilepsy, and he was being filmed working in a specialist setting, a specialist clinic setting, working alongside secondary care colleagues. And so the portrayal on the TV programme was him enacting very appropriately for the context but it wasn't made clear in the documentary. And he was actually in a consultation with a patient lasting 20 to 30 minutes, which had been carefully edited to about a less than 2-minute clip.
Yes.
So I think he subsequently provided a very clear and reassuring statement to the Facts Aware group, which I've got here. I'm happy to read it to you. I'm happy to give you a hard copy of that statement, but I found it beautifully clear in explaining what was going on. So shall I read it, or shall I just provide you a copy? So this was in email form from Dr. Andrew Hansen on the 27th of November 2018, subject GPs Behind Closed Doors, which was the name of the documentary. Dear Judy, further to our telephone conversation this morning, thank you for the opportunity to set the record straight, and I would be grateful if you could share this email with other members of the relevant committee. I was very concerned to hear that my consultation, which was broadcast by Channel 5 recently in their GPs Behind Closed Doors series, was being held up by some as an example of poor epilepsy care. As you know, I do not accept this is the case, and I hope the following narrative reassures the committee that in fact received high quality care and advice. Having viewed the video footage again, I can fully appreciate why concerns might have been raised, as taken at face value, it does appear to reveal a GP dealing with matters that should be dealt with in a specialist setting. Unfortunately, the Channel 5 documentary does not provide the context of the consultation, and furthermore, due to the skill of the editor, it's not apparent that a 20 to 30-minute consultation has been condensed to just a couple of minutes. I'm not a patient of the Ridge medical practice, the GP surgery. I was consulting with her in my capacity as a GP with a specialist interest in epilepsy in the Bradford Epilepsy Service, BES, which uses GPs with specialist interest and epilepsy nurse specialists to deliver specialist epilepsy care in a community setting close to home. The BES was founded in 1996, and I have worked within that service since its inception and have done a weekly specialist epilepsy clinic since then. I also have an interest in general neurology and have done at least 2 general neurology clinics per week during this time too. The BES has been recognised nationally as an outstanding model of epilepsy care and is fully supported by the consultant neurologist at our local hospital, one of whom in particular provides clinical governance and neuroradiology support to the service. I'm well aware of the current and previous MHRA guidance surrounding prescribing of valproate medicines for women of childbearing potential. The risks of valproate have been known for many years, and as the evidence about it has increased, we've incorporated this into our counselling and advice for this patient group for some considerable time. The consultation was filmed before the current PREVENT programme was rolled out, and at that time we were using the old risk acknowledgement forms which required women to state they understood the need for very effective contraception, but actually fell short of making this a condition of any ongoing prescription. This is consistent with the advice I gave during the broadcast section of the consultation, which represents only a small portion of what was said on the day. Whilst this may not come over clearly on the video, I'm absolutely confident that I helped a fully informed decision about her treatment that day. In the post-consultation interview with Channel 5, which was recorded over the summer, I did describe in detail MHRA advice regarding the need for regular specialist review to ensure valproate remains essential or to explore alternatives, and the requirement for highly effective contraception. Unfortunately, this was not included in the final edit of the programme, which in retrospect would have been preferable. In spite of this, I did feel that allowing the consultation to be broadcast was a good thing, as I felt it would raise awareness of this very important issue. I've been shocked to hear that it has been perceived so badly by certain people, but trust that the above does provide adequate reassurance about this particular patient's care. We've contacted the production company this morning to see what their thoughts are about including some further information about the PREVENT programme in a further episode of the documentary. I would hope for a positive response, as their main aim in producing the show is to tell a good news story about the NHS and demonstrate how hard clinicians are working up the coalface to provide excellent patient care. I expect they will be dismayed to hear these concerns have been raised. Their response is awaited. Kind regards, Dr. Andy Hansen, and then there's his GMC number and so on. So I can give you a hard copy of that as well. So, in fact, I'll take those out of my file now to remind me to give them to you. There's a few copies of it here. Okay. So does that do with that one?
Yes, thank you.
Do you want to question anything on that? Shall I just carry on?
Well, if you've got more you want to tell us, or it may emerge through our questions.
Well, that was it for that particular thing. Then there was the regulations, CPD and dissemination of updates on drugs. Shall I go on to that bit? Yeah?
Yes.
So obviously the college is absolutely committed to promoting patient safety and high standards of care. We have a very strong relationship with our patients, and I think in particular with the emergence of the narrative of patients around this investigation, it has been tragic and heartbreaking to hear what goes on. As GPs, we develop very long-term relationships with our patients, and generally regarded as the most trusted of doctors. We take that trust very seriously, and so it's heart-wrenching for all of us when we hear these tragic stories. We're committed to working not just amongst GPs, but with all relevant stakeholders to ensure effective dissemination of relevant and important information. But we are not a regulatory body, as we've said. We do not have a monitoring, investigation or regulatory function, and we're not in a position to assess compliance with any of the standards we set or the best practice we recommend. And additionally, we do not universally cover all GPs. Once professional examinations are passed and the professional qualification RCGP is obtained, membership of any Royal College is optional. And we talk about members in good standing. Currently, we believe around 68% of qualified GPs in the UK are members of our college. 68%. Some of those qualified before it was ever necessary to pass our examinations, so they were never members, and others choose not to continue to pay their subscriptions for whatever reason, lapsed members. So, in terms of how we raise awareness of members amongst breaking news or emerging stories, there are many ways that we do this. One of the more popular is I issue my chair's weekly message to members, my informal blog, and it's sort of a chatty, newsy style. It goes out every Friday afternoon. But then we have many other formats for breaking news. We have our news webpage, which is updated almost daily, where we've issued press releases on any issue of topical interest. But also we have a lot of social media outlets. We use Twitter, Facebook and Instagram mainly as our social media outlets, and we take part in a lot of media and public discussions. So just for the record, so in 2018, for example, we're on the record in printed media over 4,000 times with something related to some aspect of healthcare, and over 200 elements in broadcast media. A few of these, as it happens, relate to valproate, but we use all these methods to raise awareness of risks associated, particularly with prescribing of sodium valproate of late, but also mesh as well. Some of them were at the request of various bodies, but others because we proactively felt this was important, topical matter, a hot topic, if you like, that our members needed information and easy access to the relevant links. And just to be clear, under, of course, general data protection regulations, my newsletter is part of the baseline communication package that members can opt out of receiving. And I checked this week, and currently the newsletter goes out to 46,334 people. I think that was yesterday's figure. 46,334 people, and that is of the 53,000 members we have. So even within our members, there are a chunk who choose not to have any form of email or written communication from us. So I cannot, and we do not ever suggest that the college can contact all GPs in the UK, and we never recommend that the college is used as a route for disseminating safety messages or urgent messages about medicines or devices. That's the role of the MHRA. But of course we add caveats to our online learning and any resources we've got as swiftly as our resources permit, and once those things are brought to our attention. So as an aside, we've got a flagship research journal, the British Journal of General Practice, one of the most highly cited and highly regarded academic general practice journals in the world. That is distributed to all members who want it, and the editor of the BJGP, Dr. Roger Jones, is in contact with FactsAware and has previously offered to publish a discussion piece, an article about sodium valproate, and I understand that is scheduled for publication in April 19, and Dr. Judy Shakespeare, who I mentioned earlier, our representative, is drafting this at present with the various action groups, so that's already in hand. So with ongoing learning of GPs, we have a long history of developing resources and training for our members. We have over 700 quality assured and peer reviewed online learning modules. The joy of general practice is we cover everything. The disadvantage of general practice is we have to try and cover everything, which is very difficult to do. We have educational libraries, and we provide educational accreditation of other people's courses and educational materials as well, recognising we can't do it all. We have an online learning community where 160,000 people are registered and sign up, so that's way more than GPs. That's other allied healthcare professionals working generally in the community setting as well. And we have over 100 other online learning opportunities outside of those modules, so bite-size or rapid learning, podcasts, screencasts and videos and so on. And as part of this, we produce learning resources on sodium valproate and the use of mesh. But our ongoing CPD is reviewed constantly and updated whenever we can. So I think that was all I had to say about the CPD, but so happy for you to ask me anything I've missed.
Well, thank you very much. That was very comprehensive. Thank you. That's very helpful. Can I just ask you, I mean, you made the point very clearly that GPs have to be generalists, so they have to cover a huge, all healthcare really for their patients. But I think you do have, and I'm not sure if it comes from the college or it comes from another source, you do have GPs with a special interest in a certain subject. And I think they were called gypsies because they were...
Various names of various types, yeah.
Can you just tell me regarding epilepsy, do you have GPs who have a special interest in epilepsy?
So the issue of being a GP with a special interest in anything is a very variable thing. There isn't one standard. There certainly isn't a standard package for how we do it. Now the General Medical Council, the GMC, is trying to address that in the form of credentials, which are coming in the future, but they've been a very slow burn. So credentialing of additional interests is meant to help establish a standard which is outside the normal scope of practice for any doctor. So a neurologist could develop a credential in something else and so on. But obviously GPs, because of the broad scope of where we start from, a lot of GPs are interested. So historically, you could call yourself a GP with a special interest. There's no qualification to be a GP with special interest, but good practice would state one would normally expect someone to have had further training and further supervision. So if I give a personal example, before I trained to become a GP, I worked in gynecology. I started general practice with a natural special interest in women's health. And so when my colleagues were struggling with difficult management of patients, whether it was menopausal problems, contraceptive problems, they'd often ask for an internal second opinion. So I was the in-house GP with a special interest. But I never used the title externally because that wasn't appropriate. But other colleagues would run community-based gynae clinics alongside a gynaecologist, and what would normally happen is the consultant gynaecologist would take them under the wing, ensure they had a higher level of baseline training, and they would work in partnership. But that was not a formalised qualification. However, in something like gynecology, there are additional qualifications that a GP could do to confirm their ability to fit contraceptive implants, their ability to give contraceptive advice, for example. So there are lots of historical examples, and I'm keeping away from these in particular for the general angle. The credentialing movement is slowly taking off, and the college currently has a pilot of 2 credentials. They're dermatology and cancer care. At the moment, epilepsy care is not on that list. A lot of other medical royal colleges are looking at developing credentials, and obviously they're quite interested in whether GPs would like to develop credentials. I've not personally been approached, and I don't know if there's anybody developing a GP for a special interest for neurology care or for epilepsy. It would be a logical one. But you can see the doctor I mentioned earlier has been working as a GP with a special interest for over 20 years in partnership with a secondary care colleague. And I'm quite confident that he's been doing so very competently, and then that is why in the revalidation process it is so important that the full scope of one's clinical practice is included in appraisal and revalidation, because in a sense one is making a declaration to say that you are keeping up to date and achieving a standard that is felt to be appropriate, but there aren't a list of tick boxes that one can say that's what a GP with a specialist interest in epilepsy should do. Have I answered?
Right. Yes, that's very helpful.
Okay.
Just still sticking with sodium valproate, and you will be very aware of the pregnancy prevention programme. From the point of view of the GP, is it something really quite simple that they could ensure that the women of childbearing age actually are very aware about the dangers of taking medications for epilepsy, which is something that they, presumably people who are epileptic, they take epilim or whatever the drug is, and it is very easy for it just to continue even when they're of the childbearing age if the GP is not aware and gives them some advice. And I'm just wondering how that works, that prevention system.
Okay, so if we take the generality, anybody with a chronic long-term condition that needs medication, good practice states that anybody who was on any long-term medication should be having an annual medication review. We have a quality and outcomes framework that came into general practice in 2004, and epilepsy is one of the diseases conditioned there. And it's quite clear that you get flags in the records if somebody hasn't had an annual review of their condition, which includes a medication review. So just for any condition, we could be talking asthma in that sense. Within GP computer systems, we've been electronically prescribing for many, many years. My own practice, we started electronic prescribing in the 1980s. But certainly since 2004, when this standardisation came in, the quality outcome framework, alerts pop up all the time. And there are alerts built into the systems concerning the use of sodium valproate in women of childbearing age. And the templates that we use to check, is somebody, has this woman had advice on, are there? So if the person is there, it's usually then relatively straightforward. So the normal practice would be that the prescription is issued. So you can get repeat prescriptions for up to a year unless you need blood test monitoring or anything else more frequently, but that would be a default for about a year. Patient picks up their prescriptions, and as that's coming to the end of time, make an appointment for a review, and you would either come in and see an experienced practice sister or a GP who would go through a quick review. Have you had any fits? How are things going? And in this case particularly, I know you're on sodium valproate. What type of contraception are you using, and so on. In general, if there's any doubt at all, we refer to neurology and epilepsy services. As a GP, I do not titrate medicine for epilepsy up and down. It's specialist territory and always has been. So it's not something that GPs are generally very comfortable, unless we're in a good dialogue with the neurology team and they have said, here's a suggestion, if you get this and that, then go up by this dose or that dose. So you get plans and you get shared care arrangements, but they're written, they're agreed, and usually the patient is very much part of that three-way dialogue. And more than ever, we ask for signed shared care protocols with secondary care, because the GPs are quite anxious about being left responsible for something they don't feel confident to do. In terms of the PREVENT programme and the pregnancy prevention plan, obviously we've tried to disseminate information. I think everybody's been working to try and get that out. And what we encourage surgeries to do, and several times we encourage this, is to run simple audits of all the women taking valproate in your care. Then we've suggested from 10 to 55 years of age, look at those women, who's on it. Now then, have they got effective contraception in place? And if they haven't, then they should be being referred back to neurologists to get a pregnancy prevention plan in place. In my own practice, we did this a year or so ago, and I'm now part of a very large practice, and we found 21 women aged 10 to 55. Of the 21, 11 of them had completely cast-iron contraception. They were either sterilised or their partner was sterilised or whatever, and it was clearly documented. And of the other 10, we sort of went through, 6 of them actually were also easy to exclude once you went into it a little more carefully, but it did leave 4 women who we were just not totally happy about and referred them all straight back to neurology, so that suddenly these are people who'd been stable for years on medication. It had been documented that they knew the risks, but they weren't on a modern PPP, so we referred them back. So that's an example of what I would expect a normal general practice to have done over the past year or so as this has been rolled out. Just to be clear, that's on a baseline population of 28,000 patients. So that was 21 on a population of 28,000. That's an N of 1, but this is to give you a feel of how things have tended to work. So, and all those all now have PPPs. But does that help?
So although you have the annual review,
yes,
which actually, of course, it's sort of 9 months from conception to birth. So the annual review is supplemented by the work that you do with hospital consultants.
Oh, absolutely. So that's a baseline on any medication. You would tend to do an annual review.
I see. So going back to my initial question, which was about your promoting safety, and thank you for your examples, and you're setting some high standards within general practice. I'm just sort of wondering how you know that there is some recognition of the work that you're trying to do, and although you cannot have a compliance regime, presumably you would want your standards to be recognised and to be carried out. So how do you know whether that's happening?
We don't know. I've got no way of knowing who reads my newsletter. We don't know who complete the online modules. All we can do is provide it and encourage the narrative, use any opportunity that we have to raise awareness, but we don't have a means of regulating or checking compliance. We just, that it's not that, the relationship doesn't work that way. Is there something specific that you're looking for?
What stops you? I mean, you mentioned just now the audit that you would recommend GPs to do of women between the ages of 10 and 55, I think you said. What stops you doing a survey saying how many of you are doing it?
We can ask the question, but of course you remember the problem with the response to surveys is you get a very biased sample. If I put a question out saying how many of you did it, the people who are going to respond are those who will have done it.
Well, and that might tell you about who's not. I mean, it's just trying to get some sort of sense of putting stuff out there and actually having no idea whether it's doing anything.
No, I think that's a fair challenge. I mean, we ask questions of the membership all the time. So, we're looking for examples of something. If you're, let us know, tell us, we'll feedback. But as I said, the number of people who, in their incredibly crazy, busy lives, take the time to fill something in or return something as small. We've just done a massive consultation recently. And, a response rate of 8 to 10% is a good response to any online survey. And so I guess it's the difficulty of getting a biased sample. If the committee would like us to do it, I'd gladly put a question out. I've got no problem with doing it. It's about how meaningful the response would be, I guess, I think from an academic perspective. But if you'd like us to do something, I'd be very happy to ask the questions.
I suppose the issue for you then is thinking, well, we're doing all of this work, how effective are we being? Do we get some sort of handle on this? I mean, we could think of it in a lot of other contexts. For example, the obligation on medics, clinicians to adverse report when they feel they ought to be doing so. I don't know whether your organisation ever surveys doctors to say, well, are you doing it? I mean, what proportion of you are filling in your adverse reporting? And the levers for that then, does that sort of appear in a discussion in appraisal? Does it appear in a discussion around revalidation? If anyone's making the checks against the standards you're setting, that you pick it up through potentially the only levers you, I think, have.
So that would certainly come under the appraisal schedule. So the sort of online electronic portfolios that GPs use for appraisal, there's a very large section on quality improvement. So we take it very seriously. Certainly we were the first college to be encouraging clinical audit many years ago of members. And so quality improvement we take very seriously, we encourage, and it's absolutely an important part of an individual GP's appraisal process and the revalidation. But as I said, we don't formally as a college seek it. Our members choose to be members of our organisation. We don't regulate them. Then I think there's that difference between asking questions and attempting to mandate something where we don't have that authority to do it. I mean, if there are, as I said, very happy to explore any ideas. We've worked very closely when issues come up. I try to be very accommodating. We work with the chief medical officers to put things out and try and get things back. But I think there's also recognition of what is the role of a royal college as opposed to a role for other people. Certainly not abdicating. It's genuinely trying to be constructive.
And your process is through a digital system, is it?
Yeah, I mean, there isn't a standardised system for all general practitioners. There are many electronic platforms out there. The college used to have one, but in fact there were others that were newer and flashier, and so we stopped offering our own electronic platform for appraisal many years ago, though we have partnerships with various people offering them. But in all of them, quality improvement is a key part of it and has to be included in the 5-year revalidation cycle. So general practice was one of the first places that really embraced the whole appraisal process. I mean, my own appraisals, I think, go back to 93. 2003 was my first in sort of the modern version of appraisal. I think that was the pilots of appraisal before we went into formal revalidation cycles. But from day one, quality improvement was in there. Significant events, audit of practice, assessment of self against standards. But that isn't the same as nationally collecting it, as you were alluding to, Valerie. So
who actually appraises what the appraisee has sent in? So
in general practice, we have a series of, so it's a peer appraisal process that another general practitioner undertakes the appraisal. It's not somebody who works in the same practice as you, so there are sort of general rules which are, it'll be somebody in the same region as you, it'll be somebody of a similar experience to you, but it will be somebody who you are not friendly with or don't have conflict of interest with. But I mean, over the many years I've had, about And that's it. It's meant to be a 3-year cycle. You shouldn't have the same appraiser for more than 3 years in a row, so that you don't build up a buddy relationship with them, so they can retain a degree of objectivity. Does that
sounds good idea?
It seems, then there's a responsible officer above the appraisers, and the appraisers are all trained, and so on. The responsible officers then nationally are trained and work together. Sorry.
On the same subject, I used to be chair of the Standards Committee of the General Medical Council, but it was a very long time ago. So I'm not quite sure how it works now, but certainly it was the job of the colleges to set the standards, and they did so in conjunction with the General Medical Council, who is the regulator. And certainly in hospitals, the appraisal process is actually under the supervision eventually of the General Medical Council. They have representatives in the hospital and who link to the medical directors, and the final revalidation process is approved by the General Medical Council. And you have to be successfully appraised to be revalidated. And persistent failures in any of the respects that you just discussed would lead to questions about you staying on the register. How does that work with the College of General Practitioners?
Almost exactly the same, Sarah. So you have to have your appraisal every calendar year. It's a 5-year cycle of revalidation. So to be eligible to be revalidated and remain on the general register, you have to have had 5 successful positive outcomes of appraisal, plus meet other minimum criteria. And as you say, ultimately it's the General Medical Council that oversees that. So if you have an unsatisfactory appraisal, then there is a process for how that can be remedied. If it is just something technical or something being missed or something, if there are other concerns, then other people are brought in to try and help and remedy the situation. Clearly, if there are other issues with somebody's fitness to practice that the General Medical Council is already involved in, then it goes into quite a separate domain of practice. But the standard cycle is that you have to have 5 satisfactory appraisals to even start the process of revalidation, and each satisfactory appraisal includes an element of quality improvement activity.
And the standards which the Royal College applies are themselves approved by the General Medical Council.
Yes, so the baseline standards, of course, are our membership of the Royal College of General Practitioners professional examination, our licensing exam.
Yes.
But then the standards beyond that are around what comprises a good appraisal. What should a general practitioner be doing in each year and in each 5-year cycle? And we have guides for general practitioners about what should be in that. What we don't, however, do is have lists of clinical conditions and say every 5 years you need to have ticked everything off. It's about personal reflection on your own practice. It's about showing a breadth of clinical updates. So, somebody whose pet interest, so if my pet interest is women's health, there's no point in me demonstrating I've gone to 17 courses on women's health in a 5-year cycle. Surely what I need to be doing is making sure I've shown all the other aspects of general practice I've been to updates on. So
and who appraises the appraisers?
So that's where they have the responsible officer who is responsible for ensuring that the feedback to and from is correct, but that the appraisers are supported, are up to date with the latest guidance, because the guidance on what comprises a good appraisal does evolve too. We have in the college a great colleague called Dr. Susie Caesar, who works with the Academy of Medical Royal Colleges to ensure a degree of standardisation through the whole of medicine, because of course the boundaries between primary, secondary and tertiary care are increasingly blurred, and it's important that we're all working in a similar way and to support doctors and help them with their professional development. So the Mythbusters Guide to Appraisal and Revalidation is worthwhile. I mean, maybe happy to send you this to the inquiry if it's of any use to you, but there are a lot of resources out there, so both the Academy and our own college guides.
Thank you very much.
Pleasure.
Sorry, can I just ask,
Please.
if there's a breach then of the standards you're setting in a particular area of practice, say around management of epilepsy or whatever, a breach of those would not then immediately lead someone to be taken before the GMC? It wouldn't lead to...
Okay, so if somebody, so there was, suppose we have a tragic significant event where somebody ends up having a child who has a significant impairment due to taking valproate in this specific incident. At a professional level, you would expect that professional to be taking that very seriously. That's a significant untoward incident in the practice. You would expect that to be reviewed at a practice level, at a personal level, a case notes review. So there's a whole machinery at a practice level for how one would deal with a significant incident. If, however, there was a formal complaint issued against that doctor, so we're talking different things. So the specific doctor complaint, you would go through normal complaints procedures, and the complainant could easily go straight to the GMC and raise it at that level. They may go through the practice, they may go regionally, there are a whole heap of ways people can complain, but ultimately it's the General Medical Council that would be looking at that individual's fitness to practice. But quite separate from that, I would expect every general practitioner, every clinician, to be reflecting on significant untoward events in their practice in a structured way, using colleagues to reflect on it and learn from it, and show in their appraisal process how they have learned from this difficult clinical experience or this clinical error. And so those are quite separate things. But that is part of good medical practice. You know, the GMC is very clear about how, as healthcare professionals, we have to be constantly learning, and how we do need to learn from mistakes and reflect upon them.
I mean, we've heard from the outbreak patient groups on two aspects here. One of which is we are finding GPs who are a little bit lax about the completion of the annual risk assessment form.
Okay.
So that sort of thing, I'm not quite sure, unless the patient then takes it upon themselves to complain to somebody, but of course they may not be themselves sufficiently well versed to know what should happen, how that gets picked up.
I mean, it's difficult without having specifics to know. And obviously, I mean, the first thing is, at any point, if any patient is unhappy with any aspect of their care they're receiving, speak to the GP about it, speak to the practice manager about it. Every practice has a system
they need
for
to know. They need to know what they're supposed to have, and it puts the onus on the patient to do all the chasing.
And I think with epilepsy care, you know, this is very much a specialist territory in terms of the diagnosis and the therapeutic side of things. But there is also a reasonably clear framework through the Quality and Outcomes framework for what GPs normally do, and that's all available online for anybody to look at as to what they do. And I think it's difficult about, if the standards are there and people are reaching out, it's very difficult to know where the challenges lie. And I guess without a specific, it's hard to give you the answers you're seeking, Valerie. But what I do know is that we've got frameworks for good reason. Frameworks around trying to provide comprehensive wraparound care to patients. You know, we don't just talk about medical care.
It's when it's not working, and I'm trying to get at as to how that gets picked up.
Yeah. I mean, from a clinical commissioning group level, they have dashboards of how many points people are getting. I mean, there's a very simple thing about the points that practices are scoring in different areas. The challenge practices have is that when they try and contact, you know, practices are only as good as the data they have about a patient. So if we don't have a correct email address and we don't have a correct phone number and patients don't respond to letters, there's only so far you can go, because patients are autonomous creatures and they don't have to come to these things. We have to chase them up to X number of times. What we can't do is force people to attend, and that's always a difficult tension. So without specific cases to unpick, which I think is a helpful thing to do at times, it's really difficult to go further. I'm sorry.
Can I just ask about recognising problems when they're presenting? So if you take the case of a child whose parents are concerned that they may have fetal valvular spasm disorder related issues, or a woman who thinks she's got pelvic pain that's related to a mesh implant. How confident are you that typically a GP would be able to make the right connections when they're presented with a patient like that?
Okay. To be honest with you, a patient who comes in and says, I think I've got a complication of my mesh, or I think my child has an abnormality related to a drug I took in pregnancy, is actually very easy, because GPs know right what to do. That is definitely specialist territory. I need to refer this on to a colleague. What's much more common and more complex is when a patient comes in with, so let's take the mesh complications. If somebody comes in with vague symptoms, I don't feel well. So tired all the time is one of the phenomenally commonly presenting symptoms in general practice. Tired all the time has about 2,500-3,000 potential diagnostic answers. And so, you know, common things occur commonly. We start with are you run down, are you stressed, are you anxious? We work through a sieve of all the things to try and take a history and establish what's going on. So if you've got a clue, I've got discomfort in the area where I've had an operation, or I think there's something funny going on down below, or that really does help you hone in very quickly.
This can be 6, 7, 8 years after an implant, and the woman may well not herself, as you say, may well not attribute it to the implant.
And that's always the difficult thing. I mean, our general practice records are enormous. So A fit, well patient who's had a hernia actually will flag up quite easily that they've had a hernia repaired of some sort because there won't be much in their records. Somebody who's complex with multiple medical problems, that could be well back in the records and won't necessarily have been flagged or alerted. So we're reliant on the doctor-patient communication to try and untangle a diagnostic dilemma. However, once a patient says something like mesh, pain, site of operation, it helps us focus down very fast. So there's a huge difference between very vague general symptoms, which could be a psychological disorder, a stress condition, a hematological disorder, a physical complication of a procedure, a musculoskeletal condition. That's where the diagnostic challenge happens. I would say in modern general practice, where things are very stressed and under pressure, we have a 10-minute consultation model, which isn't fit for complex care management. I think we all agree with that, and I don't need to rehearse here the challenges we've got. And lots of people are committed to improving the situation in general practice, but we are thousands of GPs short. If people are struggling to get an appointment and they've got something complex that needs untangling and they're not able to see the same clinician repeatedly, it can take longer to get to the bottom of it. We know that continuity of care for complex conditions really helps get to the solution faster. So that's a systemic challenge we've got with the whole stressed NHS, which we would certainly recognise. In terms of the individual, somebody walks through the door and says, I think I've got a problem with my mesh, doctor. That's actually quite straightforward to me. Once I've assessed them to confirm or otherwise,
but if they say,
straight to my surgical colleague.
I've got pain in my abdomen and I don't feel right, I've got discomfort, as you say, vague symptoms.
But actually pain in the abdomen has narrowed it down massively.
Well, yes, but it's still not, they're not giving you the red flag signal that they're not using the word mesh. So what I'm trying to get at is how confident you are that the profession will ask the right questions to get to the right answer as quickly as possible, or whether it relies on the patient doing more of the work than the doctor.
Okay. I mean, within the last 2 years, I doubt there is a healthcare professional in the country who hasn't heard the word mesh. I mean, I think it has had such huge profile that I think in recent times people are pretty acutely aware that mesh can cause complications in some patients. I mean, we're also conscious that for 20 years meshes have been used in surgical corrective procedures and people weren't talking about this. So I'm not talking about the last perhaps 18 months, 2 years, but certainly in the last 2 years I really doubt there's a GP in the country who isn't aware mesh could equal complications. So if there is any recognition this patient's had surgery that may or may not have involved a mesh, I would expect that to be a red flag if abdominal pain and malaise is coming into it. But I mean, the biggest thing obviously is always to say to people, if you're worried about it, tell us. We're not telepathic. Please give us a clue what you're worried about. And I mean, the joy of general practice is that we usually build these relationships where we can have that dialogue. The frustration is when that hasn't, the patient leaves thinking, I didn't like to say I thought it was my mesh. And that's frustrating for everybody. It's frustrating for the patient. It's also frustrating for the clinician.
And certainly some of the patients, a lot of the patients who've had mesh complications that we've met and spoken to will have told us that they know more about their condition than the GP does. And the same is true in relation to families affected by valparate or fecal valparate syndrome.
Absolutely, and expert patients can be phenomenally well informed, and actually, certainly, I mean, coming to fecal valparate syndrome, I mean, it's actually, if you have got any anxiety at all that your child has been harmed by anything you've taken in pregnancy, I would have thought that just a small hint of that to the GP is enough to ring all the alarm bells and say straight. I mean, sometimes you can look at a child and it's pretty obvious that there is a problem. Frequently, you have to observe a child over a considerable period of time to establish particularly developmental problems. I'm sorry, I don't mean to tell you that you're acutely aware of this. And actually, as a GP, if in doubt, you'd be asking for a second opinion on it. You'd referring that child on quite hastily, actually. And normally, our paediatric colleagues are very good at taking those referrals and working with them and working through the challenge. If we've got any clue about medication in pregnancy, obviously fetal alcohol syndrome is more common, actually, and a huge challenge. We've got all the issues of people taking narcotic substances in pregnancy and the withdrawal. So actually, from the children side of it and paediatric referral, that's actually I would have thought a quicker one if you've got any hint of trouble. I mean, if you've known you've taken something and it's not been flagged during the pregnancy, and usually we would hope during pregnancy these were flagged as significant things. I mean, every woman who is pregnant and epileptic should be under the care of an obstetric epilepsy service, and again that's pretty clear-cut good practice. So these things should have been flagged, and these children should be being observed, these things should be being watched out for. But if we're talking historically, which as I suspect is where some of this has come from, awareness has increased a lot over the years. When I was in medical school, we were all told pregnancy and epilepsy drugs don't go together, it's specialist territory, beware, and that was just a blanket kind of warning. Over the years, the valproate has become very clear, the message has become stronger and stronger and stronger.
Do you think, so if you, again, thinking about valproate and mesh specifically, the two of them, is there anything more that should be done, or do you think awareness amongst GPs is now sufficient?
Well, we've got bigger alerts now on the GP records. That's coming up bigger and stronger than it used to, so that was upgraded. The packets of tablets have got it splashed over them large and loud.
Should have.
Should have. Oh, are they not? Oh, I don't see the boxes. I just heard that. Okay, I sorry, I thought that was already been implemented. So, it's okay, that one's news to me. Sorry, did you? Sorry.
I was just going to say, when you said that the alerts are coming up, are they ranked? Do you have bigger alerts for more prominent things? Because we have heard about GPs and fatigue, about the alerts that are popping up all over the place.
Yes, alert fatigue is a challenge. So there are. My understanding is I've never been in a consultation where one has flashed up. My understanding is they're now treated the same as methotrexate is in primary care. Methotrexate is the drug used which needs intensive monitoring, usually used for rheumatological disorders, and a big red box flashes up bang in the middle of the screen. You can do nothing till you dismiss this box. Whereas most of the alerts pop up discreetly in the corner. And my understanding is it was going to be in the format of the methotrexate alerts, but as I've never actually seen a patient, I can check that.
Going to be or already is?
I thought it already was. I thought it had been brought in. But I don't know, so that I haven't seen what I can find out for you if you weren't aware. So that's wonderful. We can find that out for you. Just call a colleague at the surgery, call up a patient. But my understanding is it's going to be treated in that way quite deliberately because of alert overload. That is a challenge, actually, alert overload. It's just the same with street signs. We have far too many street signs, so people stop reading them. Which does no good. You asked actually a question about could more be done. I think it is good practice to keep getting these messages out there. So the pregnancy prevention programme, perfect opportunity. We've got a new GP contract going to be coming in. Each year you can put out national quality improvement activities. You could ask, it would be a reasonable suggestion that as one of the quality improvement activities that practices every year, every 2 years, whatever, have to run this audit of all their patients of childbearing age and demonstrate the patients are under the care of a neurologist or have got effective PPP or whatever. That would be a good quality improvement activity that centrally general practices could be asked to do. And I would like to think that most would be going, cool, that's great, bring it on, that's good and that's straightforward and that's good practice. But you might occasionally pick one up that had been missed over the last year or two, and so which would be exactly what you're aiming to do. So you could do that. So in England that would be via NHS England. And just be clear, the devolved nations have got slightly different healthcare systems, but this is a 4-nation review, or is this an English?
No, okay. We cover.
In fact, NHS England there.
Well, no, we cover Scotland.
You do cover Scotland, so obviously it would be the relevant authorities in Scotland, but they've got quality improvement activity in Scotland too, so just be...
I have to say, we're not responsible for Scotland or for Northern Ireland or for Wales because they're devolved countries, but they have invited us because they've asked us to go and meet their sufferers and to learn from them. So I'm
really glad, because as a Royal College we cover all 4 nations, and it's quite frustrating when things are bound by the national boundaries when actually the healthcare needs are 4 nations. So I'm not conscious I have. Did you want anything more on Primodos from us? Sorry. Did you want to?
Right, yes. Thank you. One of the things that's been persistent as we've gone around the country is patients' view of conflict of interest. And it's not just in relation to general practitioners. Right. It's come up in relation to other specialists, particularly surgeons. It's been raised particularly in the context of Primodos, which was a while ago, and surgical mesh, which is contemporary. Yeah. And so, starting at the sort of beginning of this conversation, do you think that doctors should be required to register their interests on a yearly basis? and that could then be reviewed through the appraisal process. It might be some central registrar or in some other way, like say members of Parliament.
At a personal level, yes, I do. I think for the sake of transparency, it's a good and sensible thing to do. We're NHS employees, we're servants of the state. The college doesn't have a formulated official position on it because we've never been asked. However, centrally, I expect every member of my council to do a register of interest every year. We expect all the trustees of our college to do a register of declaration every year. I encourage my members of council also, so these are within the college as a charity and a membership body, but also I encourage all members of my council to sign up to Who Pays This Doctor, which is a free open source resource for people to sign up and update them. Yeah. So I mean, at a personal level, I think it's good practice, and I certainly would have no problem with that at all. I think if we have anything, we should be, of all people, we should be transparent. Our patients should need to trust us.
So moving on from there into post-marketing studies that general practitioners participate in, do they get paid for that activity?
I don't know that many general practitioners are involved in that. So if you participate in any research, so NIHR, so National Institute of Health Research activity, which many thousands of GPs are involved in, we have very strict codes. GPs get a modest remuneration for the time taken out of providing core NHS care to do stuff, so whether that's recruit patients, mail things or whatever, very clear tariff-based. Doctors don't do it for the money, they do it because it's for the common good. It's meant to be a cost-neutral activity. That's the premise of NIHR stuff. And we encourage all practices to sign up to be research ready, which is an accreditation which demonstrates that people are up to date with good medical practice, people understand consent, transparency, good research behaviour. And we have a more advanced research preparedness for practices that take part in more commercial research, so an advanced accreditation system for practices undertaking research. The commercial research is, which I think for post-marketing surveillance, so it's within the NIHR, we're very clear of the framework. If it's privately done, then I think practices can participate in it and presumably do. I don't have much hands-on knowledge of that, but I can find out more for you.
And they would get paid for that by
yes, certainly in the past practices would have been paid.
And would they be obliged to declare that interest to the patient? Say, for example,
yes,
if
and
they were...
any consent procedure should be...
If they were prescribing a medicine which was part of a post-marketing surveillance, say they were swapping one medicine to a more recent proprietary product, and they were being paid to participate in research related to that product, would you expect the patient to tell the doctor to tell the patient that?
I would.
Before prescribing?
I would, because it should be part of the patient information process and the consent process. So all ethics committees are very robust on this sort of thing, what needs to be said to the patient, and the patient information that is provided, which is usually in various formats and various ways that's accessible to the patient, should be quite clear about anything like that. So I would expect that to be the case. I don't have hands-on experience of that because my research and academic activity has almost been exclusively with NIHR studies. So, and again, I can find out more if you've got a specific instance in mind. We've got a clinical information and research centre at the college who
I don't have any specific interest in mind myself.
No.
I'm just reflecting what patients have actually said to us as we've gone around the country.
I would imagine that's less. I would imagine it was less of a big thing in primary care than in secondary care. But if you've got a specific instance, we'll try.
I rather hope it is now. But and of course, if we had a declaration of interest, which patients could interrogate, this would assist us in this. But certainly in the days of Primodos, which was in the 1950s to 78. There seems to have been Primodos tablets passed out to patients without a normal prescribing process, from what we've heard.
Right, okay.
And what was the incentive to do that, I don't know.
Okay.
But that's where some of this
so that is,
anxiety has emerged from.
And obviously that is significantly before my time, both personally and professionally.
Yes.
I mean, we can help if there's any specific question you want us to try and find out more. Gladly do that, but it's quite difficult to be going back so
it would be interesting to find out if there's any guidance issued to say that a practice can only indulge in say one or two of these direct relationships with the private sector. I mean, I have no idea whether they're free to just do as many as they choose to or not.
I honestly don't know, and certainly don't know what would have been going on 40 or 50 years ago?
Now.
It's about now. Oh, right. I'll ask the question for you. I'm not aware of any because I think it's not that common. There's not that many practices that get involved outside the NIHR governance framework, which is actually meant to get away from so much of this, to be robust and to ensure that it's all done properly. And certainly we always encourage people to undertake research within that framework for all these reasons.
Thank you.
Is that
Thank you.
Can I just ask you one other I'm back in the practice. I'm into the health centre where the doctors are working. One of the things with people who have had mesh complications, it's taken them, the patients, some time to really recognise what the underlying cause has been, and so they come in with other symptoms as well, and some of it's to do with their legs and all sorts of different symptoms. I just wonder, in the practice, I have seen notices that say, will you please stick to one condition to talk to the doctor about? If you have another condition, will you come back and make another appointment? Is that good practice?
Those signs are an unpleasant and unwanted consequence of the way general practice is being forced to work at the present time in a stressed NHS. Those practices make 95% of GPs feel deeply uncomfortable, and they are an administrative way of trying to deal with the massive workload that we have, the patients queuing out through the door. So they are not desirable, and what every general practitioner will tell you, that patients are complex, and unpicking what's really going on. You know, I frequently get people coming in with a list of 6 or 7 things, and actually 4 or 5 of them are intimately linked together. So people are complex. To deal with a medical problem properly involves looking at the physical, the social and the psychological elements of their lives and the condition, which involves exploring it. If a patient is concerned about something and they don't feel it's been dealt with in the one consultation, the is to look the GP in the eye and say, how can I deal with all these things? I'm worried. A GP will frequently say, let's book you a double appointment to spend longer unpicking all this. It is in everybody's interest to get to the bottom of a problem and not leave things hanging. It really, really is.
So does a double appointment still attract the same funding?
We're not paid. It doesn't, because unlike hospitals, general practice is funded in a totally different way. We're not funded on the number of appointments. The 10-minute slot is purely a functional consequence of having to see so many patients. If we can choose to have longer appointments, if we want to, we just get to see less people in the day. And there's just the physicality of how many hundreds you need to get through the door in any one day. But so there's no funding issue at all related to a double appointment. It's purely if you have a double appointment, another patient doesn't get an appointment that day.
I've got a final question, and I know Cyril has as well. Is there anything you'd like to tell us about Primodos?
Yes, it was just that there was something about Sky News and a documentary on Sky News. I just wondered if
seen that,
because there was a little bit of confusion about that. So, and it's obviously, as you said, it's a drug that really was before my time. But we did have some material in our archives about it dating back to the 1960s and 70s. And Sky News journalists contacted the college in January 2017, and they asked if they could have access to our archives to look at our material, which we willingly agreed to. And they referenced some of it in a documentary that was broadcast on Sky Atlantic in March 17, and I think it's subsequently some parts of it being shown on Sky News. Now the problem is that documentary conflated 2 pieces of archive material. They were both written by Dr. Norman Dean. So the first was an unpublished research study out of Dundee University, which was done in collaboration with the Royal College of GPs in Scotland, and it makes a passing reference to Primodos. And the second archive material was a letter from Dr. Dean to the college chair at the time, a Dr. Eki Kunzberg, which was specifically about Primodos. And in that letter, Dr. Dean expressed his personal view that Primodos should be taken off the market, but he acknowledged in that letter that this was not supported by clinical research, including his own research. Now, these things aren't dated, but we know that Dr. Kunzberg was chair of our college between 1970 to 73, so we can approximately date that letter.
Is that the Dundee University
Yes.
study?
I'm just looking, it's the Dundee study. Yes,
Yep.
It's the Dundee study. Yeah,
That's what I assumed.
Yes, yeah.
So that study exists, you have it,
We have the data in our archives, yes.
and no one seems to have actually seen the full study.
if anybody wants to see this, people want to see the archives, they're welcome. It said it's an unpublished, it was never published, it didn't show anything definitive, which is why it was never published. But the data exists. Yeah, absolutely.
Dean did in collaboration
as
with
Dundee with RCGP
And
Scotland.
it's the complete study, it's not just the highlights of it.
I think it's the complete study. I think we've got about 50 pages of...
Yeah, I don't know if it's complete, but
We don't have
there's
to-
substantial...
I mean, it's been
We
looked
would
at...
very much like it, yes please.
So, and as I said, well, Sky came and looked at it in the confidential, issue. Obviously, they couldn't take it away. But yes, of course, we will facilitate that, as we've previously offered to do. In terms of... fine, we'll start that up outside with the archivist and so on.
We may come back to you on that.
This is a question that we're asking quite a lot of people who come to see us. And it's one that causes me quite a lot of anxiety. We are dealing with three things that have really gone terribly wrong. And I'm conscious of the fact that it's actually taken groups of patients coming together to get action in this area, and talking to politicians to establish parliamentary health groups. And all that has been necessary for us to be asked to review it. The system, to my mind, seems to have failed. And I'm part of that system, and you're part of that system.
Absolutely.
And so the question that I'm asking is, can you think of what we might be recommending to try and reduce the risk of something like this happening in the future? And if you can't respond immediately, if you want to go away and just think about that and contact us, I'd be grateful.
We will certainly do that. I will do that. But I think certainly any device, so thinking particularly about mesh at the moment, but also the challenges we've had over the past few years about breast implants, that affected a couple of my own patients. Registries, contemporaneous, high quality, searchable, identifiable registers, really improved. Post-marketing surveillance being as easy and as slick as possible, and patient empowerment with the future technology where patients are being linked with their medical records, making it easier for patients to be able to feedback. All of those have got to be good things for the future, and I think the profession would welcome these things. I think any healthcare professional who believes that either their practice or that the system has harmed their patient, that's the worst feeling. That's the complete antithesis of what we're about as healthcare professionals. So if we can do anything to support and help protect patients for the future, we should
It's
welcome
about being able to hear the patient voice earlier.
Yeah, absolutely. And just to be clear on the Primados thing, I'm sorry, I just wanted to be, there was something I was going to say to you, it was clear, not about the archive. Oh, I'm sorry, it's gone. There was something I meant to sort of come back at you on. So the archive's not an issue.
Don't worry, because we are accessible.
Yeah.
Always come back to us.
Yes, thank you.
And I always say in closing this session, first of all, thank you so much, and thank you for bringing your advice, your colleagues as well. If you have any concerns about anything that you've said today that you felt should not be released, perhaps you could come back to us within 24 hours and we'll have a discussion on it, if that's all right with you.
Of course, that's fine. And all I wanted to say about Primados is the archive material, just to be clear, Primados is only mentioned in passing. It's a study of a wide range of hormones and contraceptives. Primados is a tiny part of it, just to be clear, not to get your hopes up about the archive. That's,
it would just be interesting because it has always been reported as missing and not available, so it would be really useful for us to...
No, we have something. I'm sorry, I can't vouch for how complete what we've got is, but we have got material in the archive. So
thank you so much indeed.
Pleasure. Thank you very much.
And thank you for all the work you do for the college. Thank you.
Thank you very much. Can I leave these with somebody? That's the statement from my doctor.